Shiv, glad you got it. All right, come on over here, Shiv. He's co-founder and CEO of Wardly Technologies.
Thank you. Thank you, and it's great to have this opportunity to present to all of you. I'm Shiv. I'm one of the co-founders of Wardly Technologies. So I want to start my presentation with this statistics from a couple of research studies. The first research study that I want to talk about is that we let patients speak only for 11 seconds before they are interrupted. That's what research says. And the other research that I want to point out is that 80% of the diagnosis can be made just with a good patient history. So that's the diagnostic paradox that we live in, right? So one of the most valuable diagnostic tool is what we seem to be cutting short. So I want to start with this, data point and diving a little deeper into the problem statement that we're trying to solve is that today physicians walk into the exam room without having any context or clarity about who they're going to see and what problems they have. So they spend the first 8 to 10 minutes piecing together the complex history, background, symptoms, pain points of the patients, right? So the result is that missed context, redundant testing, and misdiagnosis. It also leads to physician burnout, and not just physicians, even patients don't feel heard. That's a common complaint that we keep hearing, that it's a very rushed and hurried process where the patients have to explain what they're going through. They don't feel heard, right? And we don't have solutions today. We have AI scribe, but it only helps during the encounter. It doesn't really prepare the physician for the encounter, right? And then we have intake forms, but we know it's clunky, it doesn't work, it is archaic, last generation technology. So how Wardly Technology solves? So we build conversational AI agents. These are clinically trained AI agents that reach out to the patient before their appointment, typically 24 hours before their appointment, and have a very detailed, intelligent, and more importantly, empathetic conversation with the patient. We let the patient speak about their problems, their concerns, without hurrying them or without rushing them. We summarize the conversation, we bring what is clinically relevant, and we summarize and we structure that into a patient portrait, and we push that directly into the EHR. So physicians can review these notes before they actually walk into the exam room and talk to the patient. So they have full context and full clarity even before they see the patients. So how does it work? As I said, it starts with a phone call. So we are fully integrated with all the major EHRs in the country. So we pick up the schedule of appointments. So we make outbound phone calls to the patients. Patients receive these phone calls, and these are intelligent bots. So you can say that, hey, you know what, I'm busy, or I'm driving. Call me back after a couple of hours, or call me back after 7 p.m. The bot understands, and you'll get a call whenever you want it to call you, right? So, and then you talk to it like how you talk to a human, a medically trained human, right? Because these are clinically trained agents that are capable of having a full medical conversation with the patient and ask the right question. Adaptive listening, adaptive questioning, it's all capable. These bots are capable of doing that, right? So we complete the conversation, we summarize the conversation, which is the next step. We extract the chief complaint, history of present illness, review of system, and then we push that into the patient chart in the EHR, ready for the physician's review. So the outcome, we save 5 to 7 minutes every encounter. That is for a physician, we save about 1 to 1.5 hours a day. It's not just about seeing more patients, as the previous speaker said, it's also about reducing the wait times. Today, patients have to wait before they can see a physician. We free up the precious physician time so they can see more patients. And 80% of the history that the physician needs is already captured by us. So we touch upon the 3 Ps, patients, physician, and practice. Patients feel heard, physicians walk in prepared, and the practice becomes more efficient. So we don't want, this is like starting point, but we aim to become the voice layer of an outpatient practice. We start with patient portraits, but then our agents, we will be building agents that are also capable of automating appointments. We can do medication reconciliation, we can do comorbidity mapping and risk scoring. We can also make differential diagnosis because we already have the history of the patient, so we can make differential diagnosis. We can do post-visit order fulfillment. We can also do follow-up and reminders after the visit. So it's a full layer of voice-enabled AI that we want to create for our patient clinic. This slide also talks about our revenue model. We charge $3 per patient portrait that we create, but then for every additional module that we will be launching, which the clinic would want to use, we will be charging additional dollars for each of those modules. A quick slide on the market size, and so there are about 1 billion outpatient visit that happens in the United States. With all the modules that I showed you in the previous slide, we would be gaining about $15 per outpatient visit. So our TAM is about $15 billion today. But the outpatient visits are expected to triple in the coming years, so that will triple our market opportunity, which puts at $45 billion. And our target customers, our primary ICP are like the independent clinics and specialty groups. For example, GI, psychiatry, cardio, primary care. Typically that has about 3 to 5 providers, but we also are suitable for other types of health systems, which includes hospital outpatient departments, concierge clinics, ambulatory surgery centers, federally qualified health centers, and specialty networks as well. Just quickly want to talk about where we are. We are super early. We have been working on this product for a long time, but we launched only about 3 months ago, and the traction has been quite satisfactory. Just within 3 months of launch, we are already at about $600,000 ARR. We are working with 4 health systems, which also includes a very large, federally qualified health center in New York. So this is what we plan to achieve over 4 phases. We start with 10 pilot clinics. As I said, we are already working with 4. We have 6 more to go, and then in phase 2 we'll be working with 100 clinics, and in phase 3 we'll be working with 500 clinics, and phase 4, which is 2 years from now, we want to work with 2,500 clinics. Of our fundraising plans, we are doing $1 million pre-seed, out of which close to about 50-55% is already subscribed by angels who are focused in healthcare, and we are doing a SAIF with a $10 million cap. So this is our team. I'm one of the co-founders of the company. I have built a startup before, which I successfully exited. Before that, I was a strategy consultant, graduated from Stanford. My co-founder and CTO has been an engineering leader with top Silicon Valley startups. We also have a physician co-founder who serves as our chief medical officer, and then our 4th co-founder is an ex-VC. He used to manage a very large Danish VC fund that invests primarily in healthcare and fintech. We also have a couple of physicians who are on the FSA board. Yeah, thank you so much.
All right, questions?
What percent of patients complete the call, free call?
Close to about 80%. 80% of, in fact, it was our, we were very nervous about it, but we realized that patients really want to be heard, and AI is also becoming mainstream, and many of our patients who have completed the conversation actually told that they had a very enjoyable conversation.
Okay, second.
Hi, Rob Howell. I work with VC companies with startups. So, question, with the bots, do they do multiple languages?
Right now, we are capable of speaking in English and Spanish, but we continuously keep adding.
Russell, key vendor, actually met me already. You mentioned that you're integrated with all the EHRs. What do you mean by that?
Sure. So, we have built agentic AI workflows. So we don't go through the FHIR or HL7 APIs. So we have built agentic AI capabilities that basically make use of a service account login to go and do a certain pre-programmed workflows on the EHR. For example, we have trained the agents to go and look for the schedules of appointment in a certain frequency. So they keep looking at it and then extract the data and make it available to us. Similarly, once the conversation is completed and it is summarized, we have bots that are capable of taking that information and going and populating it at the relevant patient chart section.
Sorry to follow up. Do your customers have any objection to that?
No, they don't. Because this is what they exactly do if they hire a medical assistant in Philippines or elsewhere. So they are already used to that sort of a setup.
So are you saying that it goes through the front end rather than the back end?
Exactly.
Good, I like it. Right, last question.
All right, last question. I'm honored. Thank you so much. Dr. Holly Say, still practicing primary care physician. I hope everyone will be here tomorrow for a presentation I'm going to do called Clinic of the Future, which envisions something like this, but it is not reality. So thank you for talking about what could be reality or is reality already. I'm curious to know about prepping for the visit. So let's just say, for example, the bot calls a patient who divulges depression. Does the bot do a PHQ-2, a PHQ-9, assess for suicidal ideation? How do they present that to the physician? What about if it's urgent? What about if you can't wait till the visit tomorrow? What are the workflows that are in place to actually act on that? And then the packaging up, but also the urgent action if needed.
So we are specialty focused, so we don't have a psychiatric agent yet, but we can talk about GI and primary care. These are the two specialties for which we have our agents ready. Our agents are trained to detect emergency situation. So if they see, if they come across an emergency situation, they're trained to ask a couple of follow-up questions and confirm that it's an emergency situation, and we immediately direct the patient to call 911 or seek emergency help. And we also, have trained the agent. We have put guardrails to ensure that we don't continue the conversation. So we ask for the patient acknowledgement, and we try to do that a couple of more times. And if the patient is not cooperating, then we immediately end the call and send a red alert to the clinic.
And then how is that prepped for, maybe it wasn't emergent, but let's just say they did a PHQ-9 with a lot of detail. That's conveyed to the clinician?
Yes, it's conveyed to the clinicians.
You're not doing a PHQ at this point?
No, it is not. Yeah. When we do it, it will be communicated to the
Great, thank you very much.